Hello, my name is Ajay Kerai, and it is my pleasure to present to you today a case of delayed onset enteric oxalate nephropathy secondary to bariatric surgery. Obesity is a major global health challenge with over a third of US's population obese. Due to challenges with lifestyle modification and limited efficacy of pharmacotherapy, bariatric surgery is a popular management option. A well-known association of bariatric surgery, especially in the fat malabsorptive types such as RYGB, is enteric hyperoxaluria and its major complications of nephrolithiasis and chronic kidney disease. As illustrated by this diagram, urinary oxalate is derived from a combination of hepatic metabolism of glyoxylate and intestinal absorption. Dietary oxalate is in the form of relatively insoluble calcium oxalate crystals, and under normal circumstances only 5 to 10% is absorbed. In patients with fat malabsorption, undigested fatty acids in the large intestines combine with calcium and release more free oxalate, which is then absorbed into the plasma. Increased delivery of oxalate to kidneys lead to hyperoxaluria, which places the patients at risk of calcium oxalate kidney stones. Almost two-thirds of patients with RYGB have hyperoxaluria, and up to 13% are at increased risk of developing oxalate nephropathy. If this is not addressed, 75% of the cases will progress to end-stage renal disease. The mean interval from RYGB surgery to onset of oxalate nephrolithiasis ranges from 1.5 to 3.6 years. Talking about our case, we had a 56-year-old African American female with history of morbid obesity status post RYGB surgery in 2012, chronic kidney disease stage 3, chronic back pain with chronic NSAID use, hypertension, anemia of chronic disease, and lower extremity edema with Lasix overuse, who presented to the ER with worsening bilateral lower extremity edema and leg pain for a week. 3 weeks ago, her outpatient creatinine was 5.15 and baseline is about 1.7 to 2.09. Due to concerns of worsening kidney function, her Lasix was stopped by her nephrologist. The patient denied any recent NSAID use and family history was notable for SLE in daughter. On physical exam, vitals were stable and bilateral 2+ pitting edema up to the knees was noted. Labs on admission was notable for BUN of 30, creatinine of 3.74, GFR of 15, hemoglobin of 6.9, and urinalysis was normal except 1+ proteinuria. Workup for MGUS, multiple myeloma, and lupus was negative. Upon admission, IV Lasix 60 mg once daily was started. Her creatinine started to worsen with diuresis where it increased to 5.12. Decision to obtain kidney biopsy was made. As shown on this pathology image, severe acute tubular injury with associated calcium oxalate deposition within tubular lumens and arterionephrosclerosis was noted. Over a course of few days, patient's lower extremity edema improved, creatinine remained stable around 5, and urine output was adequate. Diuretics were then held. The patient was discharged with recommendations of calcium acetate 667 mg with meals, low oxalate diet, increased fluid intake to maintain at least 3 liters of urine output, cautious as needed use of Lasix 20 mg once daily, and close outpatient nephrology monitoring. For the next 3 months, no significant renal recovery was noted. GFR remained around 13 to 15 and creatinine was 4.5 to 5. Discussing the case, oxalate nephropathy is the most severe renal complication of bariatric surgery with the mean interval from surgery to diagnosis of nephrolithiasis to be around 1.5 to 3.6 years. In our case, the diagnosis came to light 9 years after the surgery. Oxalate nephropathy may have been precipitated by diuretics overuse, non-compliance with low oxalate diet, and inadequate hydration. Patients with a history of bariatric surgery who start showing signs of kidney disease need to be immediately evaluated for hyperoxaluria and oxalate nephropathy. However, such an approach is usually delayed due to other confounding causes of kidney disease such as chronic tubulointerstitial nephritis from NSAID use, chronic diuretic use, and hypertension. As a result, a low threshold for obtaining a kidney biopsy needs to be maintained in bariatric surgery patients showing signs of kidney disease, as this can prevent progression to ESRD. Lastly, diuretics should be used sparingly in patients with RYGB, and close monitoring is often required. Thank you very much.